pause button to the left. There you go.
Good morning. Good morning and welcome to Internal Medicine Grand Rounds. My immediate boss, Dr. Morley, is in Singapore these couple weeks and hopefully improving the delirium room that was set up there a few years ago. So more on that later. My name is Joe Flaherty. I've been with the division since 1995. I did go to medical school here, graduated in 1990, left for a residency at Kansas University, and then came back in 93 to do fellowship and joined the division in 95. I'd like to cover three areas, and the overriding goal this morning is to address the role of the physician and physician extenders. I will talk about systems of care, but I won't go into depth about that because of the labor it takes to implement systems. And since most of you are practicing physicians in the trenches, that's what I wanted to give you today is what do you do when you have a patient with delirium? Reminder of what I think Grand Rounds is to address difficult clinical problems in real life. So it was difficult for me to bring delirious patients here physically, so I have 4 patients to present to you. And please keep these patients in mind as we go forward. The one on the left actually is not one I'm going to talk about. Okay, the 85-year-old with AMS, acute mental status change. But the one on the left is the first one we'll talk about. And everybody probably knows this workup for delirium, otherwise known as acute mental status change. That's pretty straightforward. Work up, look for the differential diagnosis, manage the underlying problems. There's the algorithm that you'll see in most textbooks about agitation, non-pharm, pharm restraints. The problem with the patient on your right is that's the 10 or 20% or maybe 30% of patients that spend 80% of your time. Those are the patients that don't get better. And what happens when they seemingly don't get better? I'll notice day 3, patient becomes agitated. Does that mean the delirium is getting worse? 10, 20 years ago, that's what I would have said. Work him up again. Put him in the algorithm. But then he won't eat, won't drink. Everything we do for him makes him agitated. And this is the only test question I have for you, for those who like to take board exams. So the nurses have tried everything, they tell you. We've tried everything, sitters, lights, etc. You know the routine. And then they give you this sentence, and rightfully so, they're scared. Now they feel he is a danger to himself and others. And if you open up any textbook, it's going to direct you eventually to D is the answer. Maybe B, but D. So we'll come back to that. The second 2 cases are 2 men with dementia. And one has mild, one has moderate, and agitation, wandering. And again, I mentioned 10 or 20 years ago, I would always give these patients the benefit of the doubt, and I'd say delirium until proven otherwise, repeat the UA, get some blood tests, get the CAT scan. And as I'm looking around, I can see the discomfort level among physicians. There's a guy, you sighed, because in an agitated older patient, you just ordered a UA, and the nurses who are in the back here have to go get that UA and culture and blood tests. So we'll come back to these 2 patients later on. I can't tell you what we're doing for them yet. But the question might be, is this really delirium? And I don't know if any of you are familiar with the term DSD, delirium superimposed on dementia, but it's an evolving area of delirium research. And these patients have different outcomes than patients with just delirium without dementia. The delirium lasts longer. They have more negative outcomes. This is a hard group to take care of. Or could this just be dementia with BPSD. Now, I know most of you may not know that because that's in psychiatry, behavioral and psychological symptoms of dementia. And I hope it is feeling complex to you because this is never quite easy in these types of patients. Fourth patient, and I'll have to read you this one for conciseness. Our geriatrics consult team was asked to see an older male patient in his 80s during his third hospitalization within 2 months. The initial hospitalization was for a hip fracture, after which he went to a skilled nursing facility, then returned for a second hospitalization for pneumonia, and subsequently went back to the SNF, and now he had come back for the third time for weakness and shaking. So because he was shaking, guess which service he landed on? Neurology. Shaking. Maybe seizures. So he was admitted to neurology. We were consulted by them. According to the doctor who called us, he's not getting better and the skilled nursing facility won't take him back. And the family does not want him in a nursing home. He might be aspirating, his dementia is getting worse, and we've given him antibiotics. This is day 7. We've given him antibiotics. We've done every test, including MRI head, EEG, even lumbar puncture, 3 UAs, 3 within a week, and everything is negative. On entering the room, this was the 5th floor, the 5 little 4-bedroom down there. We observed a rather big man. He looks thin here, but in real life he was big. Opening his eyes only from time to time, moving various parts of his body, sometimes his head, then his extremities as much as he could. Every few seconds he seemed to get a surge of energy, would mumble something, then try to sit up, at which time the nurse would say, "Now lay back down." He would try again, then would wear out, and then close his eyes again. His wife was at the bedside, an attentive yet obviously worried lady. And you can count the number of restraints, which we did, and tethers. It came up to 10 different things. So, we need to go deeper in this area of delirium. But first, the ground rules. This is still the gold standard diagnostic criteria. And for better or for worse, it's in a psychiatry textbook. And that's okay, but that's who helps us make the diagnosis. But get to know this diagnostic criteria, because this is what is going to help us differentiate delirium or not, do the workup or not. Sometimes the workup is worse than actually not doing the workup. So how are things evolving? I'll talk a little bit about the old very briefly. Then we'll talk about the relatively old new information in delirium. Something I learned in medical school, delirium is reversible. Well, it's not always reversible. And then the new material and where the field of delirium is going. First, the old, we've known since the 90s, delirium is common. It commonly occurs in the hospital and on admission. It's commonly missed. And then, compared to patients without delirium, similar illnesses, similar severity of illness, there are negative consequences. We know these patients are hard to take care of. They go to nursing homes, they lose function, longer hospital stay. I'd like to focus just a minute on mortality, because this has befuddled me for years. Why are these patients dying at a higher rate than non-delirious patients if they have the same illness? Not every study has shown this, as you can see on the far right, but most studies show an increase in mortality. And then really what gets me is this out here, 6 and 12 months. And I guess this gets to me, and some of our geriatricians will tell you, we get some of these patients at our skilled nursing facility or back home in the clinic. And these patients struggle for 6 or 12 months, and they have a higher mortality rate. Why is that? Why is that? So a little fast forward into the early 2000s, a group of us at the VA, back when I was at the VA, I was fortunate enough to hook up with different folks around the country, and we developed something called the VA Delirium Working Group. It was really a support group for people who had to deal with patients with delirium. And we did monthly phone calls, and out of that group, we finally made a couple editorials. This was one of them. And we said, boy, this is important, and we were pushing for more screening. And you remember back in the days when the VA came up with the fifth vital sign? That was a VA mechanism. The fifth vital sign is pain. So we thought this made sense. Fast forward again a couple more years. In 2010, that VA Delirium Working Group had a national meeting supported by the VA. And then out of that came the American Delirium Society, and we had meetings since 2011. Our next meeting is next year in San Francisco in June. And other groups have done this. The European Delirium Association was about 2 or 3 years ahead of the American Delirium Society. And then the media, since 2009, at least since 2009, and from time to time you'll hear a news report in New York Times as well. So things have been evolving, and then I think 2 sentinel studies in 2013 and 2014 I think changed the seriousness. We always have known delirium is serious consequences. But the outcome, is it reversible? So here's the first study. Delirium duration matters. This study out of Vanderbilt, 800 patients, ICU, this is an ICU study. They were very good about identifying pre-ICU cognitive impairment, very good scales. Only 6% of these patients had pre-ICU cognitive impairment. 3/4 developed delirium, and then they assessed them using this thing called the R bands. I won't go into detail about that. It's just probably the best neuropsych battery we have. So it's very accurate. These are very good researchers down at Nashville. What they showed is that 3 months and 12 months after the ICU, even the young group, a good R bands, your R bands is probably about 100, most of you, maybe 120. Okay, I don't know the max. I think the max score is about 115. So good R bands is 100. These patients 3 months and 12 months later did not, on average, recover from their delirium. The older you get, the worse off it is. And even the group here, 65, some of them were at the level of Alzheimer's a year later. Now, did they miss the early diagnosis? Maybe. But the data's coming out that this is really causing brain damage. The duration issue has to do with number of days of delirium was correlated with your R-bands score. So hopefully our ICU folks, I'll talk about you guys in a little bit, we're reducing days of delirium in the ICU. That's the goal now. Not just to prevent it, but reduce it if they develop it. They did, in this study, they tried to look at medications and see if there were any correlations or associations with the type of medicine being used, and it doesn't look like it was the medicine or the sedation drugs that were causing the problem directly. Now, severity, this study is a little bit softer. In this study of medical patients, these are medical patients, they used, the researchers used this CAM-S. And we may come back to this if you're interested, but it's an objective way to measure the severity of delirium. Most of us just talk about A&O times 1, 1.5, 2, 3. That's not objective. This is objective if you can figure out how to measure it. Okay? So they did that, and they gave patients scores, and I circled the most important here. If you had high severity on that little test, your adjusted relative risk of death within 90 days was 3.3 compared to none or moderate. And your death or nursing home relative risk was also higher, just barely, but higher. So severity does have an impact on outcomes later on. So that's the first take-home message, is the duration and the severity of delirium matter. And I'll go one step further and say, we think now that delirium causes brain damage. You wouldn't believe, but this brain is the brain of a 49-year-old patient. This is a case report published in 2009. 49-year-old woman who, for some reason, I think she was in business or a CEO of some business, and she wanted her IQ tested, maybe to put on her CV. So she had pre-illness IQ testing. Not because she was going to the ICU. She had no idea she was going to be septic in an ICU. And you can see what happened to her IQ. But when she went home from the ICU, people kept saying, "You're fine, go back to work, go back to work." And she kept saying, "I just can't do what I used to do." Well, you're walking around, you're driving, you're going to go back to work. And finally someone retested her and figured out, wow, she's had brain damage from that ICU stay. So the third part of this is, where's the field going? Are we making any progress? I guess the take-home message for this one is that not all delirium is equal. We've always been trained, someone's delirious, do the workup, manage it, get them out of the hospital. First, a reminder about the diagnostic criteria. This is used in many, many different sites, and you can see the prevalence in all these different sites. End of life, very high. Hepatobiliary, hip surgery, we know it's very high. Vascular surgery, the list goes on and on. Even pediatrics now, there's a group at the American Delirium Society within the ADS, and there are a group of pediatricians that come every year now. And they're starting to rule the ball that way. Now here's another little bit longer list of phenotypes, and none of this is written in stone yet. The most common you'll see is just number 1 and maybe number 2 in the current textbooks, even the current literature. And people are talking about post-op delirium a lot. People have not kind of hung on to this intrinsic, extrinsic yet. But as you see, as we start to look at different phenotypes, we might be able to move the field forward. Now, the next few slides are about the neuropathophysiology. And yes, on purpose, I've put these in to make you feel like this is way too complex. All right? So you can see 1, 2, 3, 4, 5, 6, 7 different basic mechanisms, and this is a pretty simple diagram. This guy, Dr. Maldonado, is a psychiatrist at Stanford. He published this paper in 2013. He's modified it recently, 400 references in the paper, and now it's becoming even more complex because more data is coming out, both basic science and clinical. And it is true, I'll come back to this, the neurotransmitter dysregulation is one of the common pathways before you get acute brain failure or delirium. That does happen, but not always. Some of this is network disconnectivity. I'm not going to go into these separate ones, neuroinflammation, et cetera, except just to show you, again, how complex this is with all of the different neurotransmitters, cytokines, etc., and depending on the type of, there's hepatic encephalopathy for the liver folks, trauma, alcohol, a lot of different things are going up and down. Here's the neuroinflammatory hypothesis, systemic inflammation, overwhelming infection, interleukins, etc. I thought you might enjoy this one of the many, post-op delirium. So all those family members that say, my husband was fine before the operation, I think it was that darn anesthesia. And we all say, well, it's been days. It can't be the anesthesia. It's been days. Well, she might be right. That worried wife might be right. Because now what we think is some anesthetic agents cause an impairment in the BBB. And that, this guy calls it a leak cloud. But stuff is getting through to the brain that shouldn't be. There's actually mice models that show this as well. This is not human models, this is a mouse model. But something happens. Something happens. Other models, neuroendocrine. I didn't put the ones in about sleep, but Dr. Burry can tell you about sleep deprivation and brain changes. Very, very important. And then I added this one just for interest's sake, this disconnectivity hypothesis. And this is based on pretty good data from functional MRI. Here's the person before delirium, things are connected, especially to the frontal cortex. But once a person has this person with delirium, they lose that connectivity. So they're just working on the part of the brain that might be causing the agitation. So this area is evolving. Again, we're trying to push forward to identify the precipitants, stroke, heart attack, for example. What is the neuropathophysiology? And once we can make those leaps, we'll probably make some progress in delirium. Okay, until then, what do? Well, I have to say that there are many reasons why antipsychotics are not a good treatment. And I'll start off with an easy one. Dr. Walden is here. I appreciate his advice over the years, but he teaches this to the med students. And I learned this in med school. We're still teaching it in med school. Well, Angela told us this the other day on rounds. Because that's what's still in the textbooks. We haven't gone beyond this. And this is a well-recognized textbooks. Very low dose, typical or atypical, administered on an as-needed basis are effective. Well, let me see if we can figure that out. This is a well-respected geriatric medicine textbook, and it says similar things. It's okay to use these if you failed non-pharmacological restraints. So that's wrong. This is wrong. So D is the wrong answer. We'll come back to the right answer, and I'm going to give you a little hint. I'm pointing to it. So why is it wrong? Here are the drugs, and then here's what you're trying to do with these drugs. You're trying to pinpoint one part of the mechanism of delirium, the neurotransmitter dysregulation. And let me blow this up for you. See this little mechanism here? This is what that looks like. So you're really taking a dart and throwing it against the wall, hoping to hit some of these antipsychotic the receptors of these neurotransmitters. Adrenergic, dopaminergic, serotonergic. So it's a good idea, but you don't know which of these neurotransmitters are going up and down in which delirious patient. We don't have the blood test yet. And these darn drugs, they are not simple drugs. These are not cardiac drugs with beta 1, beta 2. These are drugs with 1, 2, 3, 4, 5, 6, 7 different receptors. So you don't quite know what you're going to get. Olanzapine, muscarinic. Look at this. Sometimes quetiapine makes people sleepy. Sometimes if the serotonergic receptors are hit, they become a little more alert, agitated, potentially. And so this is what it's like trying to use these drugs. Once in a while you get lucky and you think, boy, last time I used that drug, that person calmed right down. Again, this is a little bit old, 2011, but I put it in here because I want to warn you, if you go to the literature, you're going to find case reports, you're going to find little studies of 10, 12, 20 patients, and they're going to claim, look, our patients got better on these drugs. Well, very few of these are placebo-controlled. In fact, only one of the studies in this review was placebo-controlled. This was our latest review. This came out in Clinics in Geriatric Medicine. It wasn't a systematic review, but we looked through the literature in order to publish this review article. And we tried to identify every single double-blind placebo RCT, randomized controlled trial, in different areas: perioperative, ICU, medical, and palliative care. And here's the up-to-date news. This is the sad part right here. Medical, non-ICU, there is currently one well-done, double-blind, randomized, placebo-controlled. 20 patients in each group, negative study, placebo versus quetiapine. Let's look at the perioperative. Here's the 6 perioperative. Actually, there's 7 in this review. This review by Karen Neufeld, very well done, systematic meta-analysis. Even if you take, the argument when they published this was, Well, what about this? You take that out, but her analysis still showed no significant difference, even if you just use these. Here are the 3 ICU studies. I think we have time. We do have time to, a little bit of detail here. Well done, placebo-controlled, Haldol versus placebo, Haldol ziprasidone versus placebo, and quetiapine versus placebo. These are 2 U.S. studies, 1 in the U.K. And here's the standard measurement in ICU, is the median number of days alive, delirium-free, and coma-free. You can't put people in a coma and say, oh, they're not delirious, because that's lower than delirium. Here's delirium, here's coma. Coma comes out, you might go through delirium, and you finally get free, delirium-free days. You see the results, intervention versus control, 5 days versus 6 days. Intervention versus control, 14 days for the Haldol, ziprazidone's 15, and this is the placebo, 12.5. Fewer days, not statistically significant. If you make it into hours, Dr. Devlin, a really smart PharmD, I know him, he's a very good character. He changed it to hours, got a significant difference. But maybe this is working. This was the lowest of the bias ratings, though. These were 2 well-done studies. So they're still working on this in the ICU, still trying to make it shown that antipsychotics are useful in delirium. But I think they're going to hit a dead end. I think they have been. Lastly, the palliative care. We've known Mira Agar. She's been coming to the American Delirium Society for several years now and talking about this trial, and she finally got it published last December. We were all excited because many of us believe that antipsychotic drugs are not useful. Now, take this with a grain of salt. This is palliative care patients at the end of life. And as I already mentioned, palliative care patients, a lot of them become delirious. They use a delirium symptom index, and as soon as the person reached a high delirium symptom index, they gave them risperidone, Haldol, or placebo, and as you might see, the placebo group had the best improvement in the delirium symptom index. All right, and here's, again, take it with a grain of salt, but at least we can say these are probably not that safe of drugs. Risperidone versus placebo, a trend towards more likely to die. The Haldol, there is significant difference, and median survival was different. So everyone always, when I show them these data, people say, well, what else can we do? What else can we do? And I said, well, first, do no harm. Let's not use these. What would happen if you don't use anything? Take a chance. Take a chance. And then I have to show them, well, what are we going to do? So now I'm going to show you what you're going to do, or what you can do, some options without using these drugs. I'm going to focus on the physician's role. So this is a system-based intervention, but I wanted to show it because it does apply to us, almost 20 years old. Multi-component means it takes a team. So a team of people, the nurse, even the social workers involved, volunteers are involved. We have to screen these patients. This is the screener. Do patients in the hospital have these problems? If they do, then here are the interventions. And as you can imagine, we're not going to go in there as physicians or physicians extenders. We do it sometimes, but we're not going to be pushing the fluids. Here, drink your water. We do it on rounds. We all do it. Drink your water. But this is the team approach. Visual aids, etc. But the results are pretty good. This has been replicated in the U.S. several places. You cut your delirium rates by about 1/3. This has been replicated in the place I was at last year in China, at West China Hospital. This group of nurses, Ms. Wong was amazing. She did this on 6 surgical wards with Dr. Ye, who's a geriatrician. The intervention, I'll show you. Intervention group had an incidence of delirium post-op of about 10.5%, while the usual care had a rate of about 19%. So it can be done. It can be done. What's the physician's role in all this? Well, what can we do? First is don't be afraid to identify people with a cognitive impairment. We have screening tools, the RCA, the slums. Don't be afraid to use those. Sleep-wake cycle, we can all have an impact on that. You can put an order in for don't do vitals after 11 p.m. if you want, as long as you think your patient's stable. Hydrate these people. I didn't show the data, but the brain obviously, the brain works better when it's hydrated. Okay, there's animal models to show if you dehydrate the brain function deteriorates. And we think this is the same for humans. Don't add medicines. And then this is a big one. Please don't order bed rest. Then therapy comes by and we can't see them today because they're on bed rest. And then physicians, again, ambulation as soon as possible. And then get rid of unnecessary beds. So that's the prevention part. Now let's talk about treatment or management. Management. Here's the management, principles of management. And this sounds kind of soft and cushy, but this is based on 20 years of experience in our delirium room up on 9 North in St. Louis University. And then the activate and ambulate is based on ICU studies. So let's look at where this comes from. Tolerate, anticipate, don't agitate. The delirium room developed in 1997, really the brainchild of Dr. Morley, but then he said, we did this and Flaherty take care of it, so I was up there all the time. And the biggest thing I did was we were working with the nurses every Thursday morning. I remember being up there. 7 a.m., catch the night nurses and then catch the day nurses, go into the room, see what kind of experience they have. Physical restraint free. 9 North has no physical restraints. It shouldn't have any physical restraints. That might be different than other floors on 7 or 8 or 5. And the real key is the close observation and let these patients move around. This was a retrospective chart review, so there's some limitations to this data. This was an age-matched, DRG-matched study, and we showed that the length of stay was about the same in delirious versus non-delirious, which is kind of unheard of in delirium. There's some data on previous studies about length of stay. We weren't perfect. About 26-25% of the patients received some drug. So the goal is still 0. But in the beginning, this is better than most in the literature, which shows rates of 60 to 70% of delirious patients get some sort of medication. Then in 2003, we were at DePere. We opened a geriatric unit, acute care for the elderly. And within that unit, we opened a delirium room, a 4-bed room. Same thing, and we did a prospective study this time, screening patients for delirium versus not delirium. Our best outcome is an improvement in ADL, improvement in function. You'll notice that the delirious patients on admission had a much lower function than the non-delirious patients. But they improved. And this is an element of activity in the delirium room. Didn't do great on length of stay, half a day longer, but non-significant. Then this piece of data from both studies, we were not impressed with it, the first study, because it was a retrospective chart review. We thought, well, that's a fluke, it's a small number. We didn't really publish this part of the study. And then the DePere study showed, well, maybe there was a little higher rate, not significant. But these rates were so much lower than previous studies, similar to these groups. This has been replicated in China, I forgot to mention. But then what happened is a few years later, a few studies came out of Australia who had similar close observation unit, similar models. A delirium bay, very similar to what we have, and the DASU, the delirium and surveillance unit. So one study was pre-post, one had a control group, and this was also pre-post. And their data suggested, this is the intervention group, or pre-post, but these 3 studies suggest maybe there might be something to this improved mortality rate. in the hospital. No one has data on what happens when they get out of the hospital. Now to the ICU, what we've learned, I forgot to mention what tolerate, anticipate, don't agitate. Tolerate really means let these people move around. Okay? I know the nurses are cringing because the fall rate. What about the fall rate? You can't tolerate these patients falling. Well, there are methods at this. As you get people out of bed, you're there. You let them move around while you're there. And then you anticipate. You know why they fall. Because they're going to go to the bathroom. Anticipate means taking them to the bathroom. Don't give an old man a urinal, please. If I'm 80 in the hospital, don't give me a urinal. Walk me to the bathroom. That will make me less agitated. And then don't reorient it. I know we've all learned this in medical school and nursing school. If the confused patient, tell them what day it is, tell them where they are, and if you keep doing that, they'll probably get agitated. Just go with wherever they are. Let them be who they are and get them through the delirium. Now the activate, ambulate part comes from, this is the first of many studies. These are, Schweikert is I think she's a physical therapist or occupational therapist, but this was a sentinel study where they got people out of bed on the ventilator. This controlled trial, intervention versus control, all of these patients were ventilated. Very sick, Apache scores were pretty high. And here's what they did. They started day 1 to 2. The researchers came to the American Delirium Society and talked about this study. We asked them, why did it take you so long in the intervention group, 2 days? Well, the consent. The consent took a little longer. So sometimes patients started on day 2. But usual care, about a week. And you're not walking them on day 1. You're just getting them out of bed, sitting, standing. And finally they get walking. So, and their outcomes, for me, this is wonderful. ICU days, 2 instead of 4. Functional return, 59% instead of 35%. Ventilator-free days, length of stay. None of this big difference, but there were some good differences. Here's Dr. Giamcana. I contacted him about a week ago, and he said he couldn't be here. But these are his slides, and Julie Rosenfeld is part of this. I know the fellows and young faculty are doing this early mobility. I love this inclusion criteria, all ICU patients, except ones who don't meet inclusion criteria. And here's the exclusion criteria. Most are reasonable, and I'll talk to Dr. Giamcana or take this back to him. I think this group, the severe agitation, they may be benefiting from this early mobility. So think about that. A lot of training, a lot of competency goes into this. You have to be able to deal with these lines. My gosh, a lot of training, pharmacology about all these medications and their side effects, more training, contraindications with respiratory, etc. And of course, additional training for tubes and lines. So this is not easy. You can't do this with one person. And successes, we don't have hard data yet, but I'm hoping you all are collecting this. And there's just some of the group. I know that's not everybody. And as you can see, this person, there's 2 people, and then here's 3 people. But you can imagine what impact that could have. So keep it up, guys. ICU folks. Look forward to great results. Okay, so we've covered the main objectives. Now we have to go back to our patients. The first approach here, day 3, first step is, does the patient have delirium or not? Because if he has delirium still, or worsening delirium, you are going to have to do the workup and order the labs and all that stuff. Okay? So go back to the criteria. Go back to that criteria and focus. Don't focus on 2, 3, 4. We already know he's had the acute change. He has a general medical condition, and he's been fluctuating. So for people like this, focus on level of awareness and level of attention. Those 2 key components. Second part, take agitation and put it aside. It's important that he's agitated. It's a clue, but it's not part of the criteria. There's nothing in the criteria that says agitation is delirium. It can occur with delirium, but it can occur with a lot of other things. In fact, if I go one step further, if we could, as a group, stop using the word agitation. I don't think it helps any. If I go into Dr. DiBiscelli's office and have a meeting about myself as faculty, and he says, "Flaherty, you're agitated." That makes me feel it's all my fault. But if he says, "Flaherty, you look a little unhappy or a little dissatisfied today," I'll say, "Yeah, let's talk about it." So maybe this is the terms we need to use with our patients. Or difficulty. "Flaherty, you're not coping well." "Yeah, I'm just not coping well. I need to." So use these terms instead of agitation, because once labeled agitated old man, then there's no turning back sometimes. Okay. So back to this patient. So I tell you, maybe he's agitated, but you go in and he's looking at you and he's like, I hate this bed. They won't let me out of the bed." Oh, well, that's not delirium. He's looking at you, telling you what he wants. Or "Get this catheter out." Or "Quit sticking me." So there's a fine line. Is this delirium or agitation behavior problems? But try to separate them. Then you don't have to do the big workup again. So back to that patient. Now you know the right answer. And this is not easy. Who's going to be the one person? I've done it before, and I've done it before with very agitated, strong men. A little easier to do with little women, but an older man who's, you stand there next to the bed. This is the tolerate part. I'm glad our chief nurses are here. You stand close enough to the bed that they're not going to slide out and hit the floor, but don't get so close that they're going to grab your stethoscope or your badge. And prepare for this. Doctor's going in, don't put the stethoscope around your neck and lean over a confused patient or your tie. Step up and then just unleash them. See what they do. Okay, and that's a little more tricky in the ICU because they've got so many tubes to pull on. But if you can do it once in a while, take the mitts off. See what they do. See what they point to. Gives you clues. If they do this, you unleash them, and they start doing this, oh, you've got a clue. You've got a clue. Something's going on in their abdomen, maybe suprapubic, maybe they got urinary retention. Maybe they just got an itch. Yesterday on palliative care rounds, we saw a man, and he was squirming in the bed. He's agitated, the nurse said. So we sat him up on the side of the bed. He's like this. And as soon as the medical student rubbed lotion on his back, he's like, as calm as could be. We cured his agitation. So this is not easy, but it's so much more effective than the Haldol. Now, what if you have dementia, and this is where it gets even more complex? Go back to the gold standard. Stick to your gold standard. And let me make it easier. Get rid of 2, 3, 4. There. Focus on the level of awareness and attention. Use the family and say, is this his normal level of awareness? What? Is this how aware he usually is? Yeah, this is the way he is. No delirium. His attention. You can test attention days of the week backwards, months backwards, but just ask the family. What do you think about his attention? Oh, he's not looking at me. He's not paying attention to me like he usually does. Abnormal attention. Delirium to prove, in other words. Look for the cause. But if the patient's just got these things, separate it. That's the behavioral and psychological symptoms of dementia. Now, sure enough, patients can have both. This is not a strict line. And here's where, if I can go one step further for complexity reasons, this is what we think is going to be our new model of delirium. Delirium, the DSM, full criteria. You have to have a precipitant. We know there's something going on in the brain. And then you have the syndrome, the signs and symptoms, but you also may have the neuropsychiatric symptoms of delirium. Take these two and separate them. Separate those two. When you're trying to differentiate between delirium, the syndrome, and the neuropsychiatric, separate those two, and here's what happens. If these are getting better, if the awareness, the attention is getting better, then the brain is getting better. The delirium is getting better. So hold your horses. Stick to your course. Continue the IV antibiotics. Continue the treatment. Don't change. Don't order another chest x-ray, another UA. Patient's getting better. If these are the problem, these are so dependent on the environment and the underlying dementia, they should not be used to measure success or non-success of treating the delirium. So just separate them. And then you have to address both of them, but separate them from the physician standpoint. And then both groups, whether you're delirious or whether you just have the neuropsychiatric symptoms of delirium, both can benefit from that TADA method. So, we have 3 or 4 minutes. Let's go back to this gentleman. And I think I'm going to close with a couple conclusion slides. This is a Saturday, by the way, and I'm with the fellow. And this was our consult, saw the patient about 11 o'clock. So I'm still in there on the first visit, and I asked the patient's wife, would it be okay if we try something? I know he's a bit agitated off and on, and I know he's a fall risk. And I know he may try to pull the IV or the feeding tube, but I'd like to start undoing some of these things and just see how he does, to see if we can get him out of bed. With a hesitant but hopeful smile, she said, that would be wonderful. He hasn't been out of bed in days. As we know, in skilled nursing facilities, they get people out of bed every day. So that's where he was, getting out of bed every day. Now he's here. Hadn't gotten out of bed in 7 days. So one by one, we removed the tethers and the restraints. We got to a point that he was free enough to allow us to try sitting him up. Although he was a big man, we, with a lot of help from him, despite his confusion, were able to get his legs on the side of the bed. He did not have good sitting balance, but appeared that as he became sitting up more, he became more alert. And as he became more alert, he was able to sit without falling. So yeah, when you first sit someone up that hasn't been up for 5 or 6 days, the cobwebs need to clear, or they will fall down. But give them a chance. Again, what's the worst that's going to happen if they fall back? They're in the bed. So give them that chance. Sit them up. See what they do. And I guarantee you, I wish Matt Burr was here, our nurse practitioner that does rounds with us on geriatric consults. But when we sit delirious patients up, bam, the lights go on. Like our patient yesterday. He just, after about 5 or 10 minutes, takes a while, he started talking to his wife. And what does his wife say? That's the best he's talked in days. We didn't do anything. So we almost stopped there. I could see the fellow had broken a sweat at this point. He was in the back, I was in front. But I knew we couldn't because the patient started to move as if wanting to get out of bed. The nurse at this point was not too happy, but tolerant from a distance of what we were doing. The wife's mood began to change from one of anxiety to positive expectation, especially as I strategically moved the chair closer to the bed. Not far, I moved it closer. With the gait belt in place, which was no easy task, the fellow and I made our move. It worked. He still had enough leg strength. 2 months ago, he had a hip fracture. People were still afraid to stand him. He had a hip fracture. Well, it was 2 months ago. That's healed, baby. That hip is good. And that's why we do the surgery, so you can get out of bed. He couldn't step very well, but eventually he made it to the chair, and 45 minutes after we entered the room, he took a deep breath, coughed, cleared his throat, looked over his wife, and that's better. So, that's that. Here's the conclusions. Agitation is not delirium. Use those criteria, especially that number one criteria. Awareness, attention. Awareness and attention. Don't forget those two words. If you can identify awareness, whether it's your renal patients, your liver patients, any of those, awareness and attention. Those are key. And then use those to differentiate if you have people with dementia versus delirium with dementia. You can use this level of arousal, awareness, alertness. If they don't have this problem with arousal, awareness, alertness, don't continue to do the workup. Or if these things are getting better, you're doing good on the delirium. Keep going. This will help you not do the workup sometimes. Then lastly, this area is very complex, and we're hopefully going to move towards phenotype. So renal patients with delirium are going to be very different than liver patients with delirium or ICU patients. Probably the end result is delirium, but the mechanisms are probably subtly different. And even for 5 renal patients, they could have 5 different mechanisms of variety going on. And I would emphasize the goal really is 0. We should probably measure ourselves on how often we use antipsychotics. My goal was always 99.9% once in a while. But that's, when I go in to see a patient, that's my goal. And then everyone deserves to die. Okay, thank you very much. Yes?
I've seen increase in the frequency of using Seroquel for agitation and delirium.
Yes.
Especially in that situation. What's your recommendation on using that? When do you use it?
I never use Seroquel. That's the 99.9%. The reason it has become popular is, a couple studies have tried to use Seroquel, but it sedates more than Haldol. So experiential, if you talk to folks who have done this for years and years, they try Haldol and it doesn't knock people out. But Seroquel sometimes does. But my answer is never. Don't use antipsychotics. No, it's wrong. It's wrong that we're using these. Now, Seroquel and those, let me just stop there. It's just wrong. Call me before you use Seroquel. Would that be okay? Yeah.
I just want to know, when do you use it?
I never use it. I can't remember the last time I prescribed it. If someone has bipolar disorder or schizophrenia, but there's no FDA approved indication. There's no drug FDA approved for delirium. I didn't put that slide in here. People are trying, but it's just, do something else. Yeah, it's hard. It's not easy. I'm not saying it's easy. Yeah, Jerry.
The biggest problem I see in the board is people don't get out of bed. I'm just horrified by how many times people get out of bed days.
Yeah.
Especially because of our why do people have to get there?
That's actually a good idea. I know we had some nurse leaders here, and that not just physicians' role, but nurse leaders' role is. That would be a wonderful idea to have a team of mobilizers. You could call them the mobilizers, and go around and get them out of bed every day. There's a clear correlation between getting people out of bed and improving delirium prevention and treatment. That study I showed with the Beware, Prevent, and Ambulation ASAP, the biggest intervention there was volunteers walked patients. Volunteers got people out of bed. Yes, and then...
A lot of the non-pharmacological treatments that you showed have a lot of efficacy, but it seems to put a lot of labor intensity on the medical teams. Do any of the studies that you looked at list what the nursing and patient ratios are, and if so, is there any correlation between having lower nurse-to-patient ratios?
Nurse-patient ratios. I don't know of any data that shows if you decrease or increase, there's an increased risk of delirium. The studies do measure this when they do the non-pharmacological. They're very careful about trying to measure how much more effort there is. For example, our studies with the delirium room, there was one extra nurse aide person per 20 beds. Instead of 2 per 20 beds, we had 3 per 20 beds. The ICU studies, it's very clear that you need a PT and an OT, and you saw all those people. It's very clear you need more people power. There's no doubt. Cost, when we calculate the cost, though, of prevention and getting people out of the ICU, whether it's on the floor or out in the ICU, cost-wise, you save money. Okay, these are soft data, but that's as far as we go. Great question, though. It is labor-intensive. Yes, Dr. Olson.
What do you think the role of working nutrition might be in this whole process? Protein, calories, vitamins. We count ourselves in the back. We get somebody either in fluid in a day that's 75 cc's an hour. They get 300 calories of dextrose, which is 2 sodas.
Yeah.
So what do you think the role is, and is there any data?
There's not direct data where if you make sure people are nourished and you give them a lot of protein, you can prevent delirium. What we do know when you do the observational studies and you look at all the multivariables that are associated with delirium, nutrition comes out in those studies. And they measure whether it's low albumin or other ways, frailty. Undernutrition is a huge risk factor. That's huge. It's a risk factor. It's not the biggest one. Dementia's the biggest, and then you've got other things. I don't know if we can prevent delirium just by making people eat. I will say, though, I forgot to mention this, and I really want to. Everyone orders speech therapy, or these patients get speech therapy evals, and then they get labeled NPO. So back to Dr. Mahon's question, I think most of our speech therapists do the eval with patients still in bed. And they try to sit the patients straight up, but you just can't get a good test. Our patient yesterday was NPO because of aspiration possibility. He failed to swallow. When we sat him up on the side of the bed, once his brain was on, he took ice chips and water and did fine. So that, I think, is important, and then people will start eating. Yeah, and actually there are some observational studies that show delirium affects ability to swallow. And as the delirium clears, your dysphagia improves. Okay. Yes? Oh.
At night is when most of the drugs are given because less staff, you have less, even fellows are less stressed, so breathing is not needed, it's not very good. So when patients come start to move around, this is where the drugs are supposed to be. The answer is to actually address that at night when less staff. But during the day, I think we're doing good in the sense that the patients are being mobilized at least once or twice a day.
Wow.
But instead of benzos, are mostly given at night. Sometimes they continue to give the day because they're just at night.
That's right. You got to stop that snowball from rolling down the hill. That's a great question. I don't think anyone's figured out a way to address the nighttime problem of getting people out of bed when they want to. Everybody thinks we need to keep them in bed. And that may be why people are using the drugs. So it'd be great if you guys could make an intervention that says when people want to get out of bed in the middle of the night, you get them out of bed, wait till they're sleepy, then put them back. There are some protocols out of the Nashville group. They've done some sleep protocols for ICU folks. But that's to promote sleep. And you're really talking about the other side. That's very good. Good question. Nothing I know of. Yeah. They don't have to walk them. Yeah. So our delirium room, at the pair at least, at night, people are walking at night. That's part of the thing. That's right. I don't know if therapists would ever work the night shift. if it reduced length of stay in the ICU. Okay. All right, thanks everybody for coming. Adrian. Oh, thank you.